Hello and welcome to a new episode of eHealth Matters. I'm Dr. Oskar Wenbar, and today we have a very special guest on for you. Professor Geoff Hackett. He is the head of urology and sexual medicine at Aston University, as well as the past president of the British Society for Sexual Medicine. Professor Hackett, can you tell us a little bit more about your background?
Yes, I've run a clinic in NHS in Birmingham for over 30 years. I've also published around about 100 papers on the subject, and probably in my time I've treated a couple of thousand men with sexual problems.
Amazing. That's really impressive. Thank you. The first thing I wanted to talk about, Professor Hackett, is erectile dysfunction and kind of how common is it amongst men? Can you tell us a little bit about that?
Erectile dysfunction is incredibly common amongst men. It's estimated that about 40% of men over 40 and 50% of men over 60 and 60% of men over 60 suffer from some form of erectile dysfunction. So it's a really common problem. And why it's so important is that it's often associated with important underlying medical conditions. And it's the first sign, so that we need to ask patients about the problem, because it can come on years before the actual medical conditions such as blood pressure, diabetes, raised cholesterol, heart attack, enlarged prostate, lots of important medical conditions.
And what's the difference between maybe the odd occasional performance issue and actual diagnosed erectile dysfunction?
Well, the definition of erectile dysfunction is the ability to attain or maintain an erection sufficient for satisfactory sexual activity. It doesn't mention whether that's all the time or once in a month, but generally speaking, it has to be a consistent problem. So any man can have a problem one-off if he's had a few drinks, or he's excessively tired or worn out from a hard day's work. Of course. So we're talking about a persistent problem on many occasions. And the most important question to ask is about morning erections, because morning erections are when the body goes on to autopilot. So if men lose these morning erections when they wake, then that's much more suggestive that they have a medical condition causing their problem.
I see. And is this a sign that you would look for as a precursor to something more dangerous, or a sign that there's a disease in progress?
Yes, because basically what the body is telling us is that it's unable to get the right amount of blood through a rather small artery down to the penis. And small arteries will tend to get blocked well before bigger arteries. So if you begin to get problems with getting blood flow down below, it means that in 3 to 5 years, if the same conditions continue untreated, you'll be getting problems with bigger vessels later on. For example, the heart or even the brain. So it's important that we don't just put it down to stress or something else, that we always take it seriously when the problem arises.
That's really good to know. I think we've touched a little bit about morning erections in previous podcasts, but it's good to hear it from your perspective of this being a really a big early sign into seeing that something is potentially wrong with the person. Just going back to erectile dysfunction and the causes of it, can stress and anxiety itself cause erectile dysfunction?
Yes, it can. But in those cases, it's normally only occurring when the person is in a condition of stress. So therefore, it will be the occasional time. There will be times when things are perfectly normal. And as I said earlier, the morning erections are always crucial, because when you sleep, you go on to autopilot. The stressors tend to have gone. So if you lose those early morning erections, that's always a vital warning sign that something organic is happening. And if you think about other conditions, for example, if somebody got short of breath or had some pains or palpitations in their chest, you'd expect the doctor to go out of their way to exclude a serious problem before putting it down to anxiety or stress. So in the same way, we must presume that erectile dysfunction is due to one of these organic medical conditions before putting it down to stress. It should be a diagnosis of exclusion if we conclude it's stress.
Okay. No, that sounds perfectly logical. So we talked a little bit about risk factors. Can you tell us maybe a little bit more about how conditions like diabetes, heart disease, and high blood pressure can affect erections and cause erectile dysfunction?
Various medical conditions can affect erections in a number of ways. For example, if the blood pressure is raised in the arteries, then it becomes more difficult for the heart to pump blood against that higher pressure. So therefore, less blood will reach the arteries that are at the end of the line. Likewise, if you have raised cholesterol, the cholesterol tends to fur up the smaller arteries before it affects the bigger arteries, just the same as if you had silt blocking a river, a smaller river would block before a bigger one would. In terms of diabetes, diabetes can not only affect the blood flow, it can also affect the nerves that send messages down from the brain and also back from the penis to the brain when the person's being stimulated. So nerve damage associated with diabetes can also cause erection problems.
I see. So how common would it be in someone that's a type 2 diabetic, for instance? How often would they experience erectile dysfunction in your experience?
I've published a number of studies in type 2 diabetes, and we've shown consistently that round about 70 to 75%
Wow, okay.
of men with type 2 diabetes will have erectile dysfunction. So it's really not a matter of if, but when. If you have type 2 diabetes for long enough, erectile dysfunction is virtually inevitable. And often the treatments that we give to treat the type 2 diabetes can actually make the erections worse. And if we then throw in such treatments as painkillers or antidepressants, then the effect of all the medications can be adverse.
That actually brings me on to my next question. So are there any common medications that you see that are big culprits for causing erectile dysfunction?
Yes, a number of medications can be a problem. Anything that affects the brain, such as antidepressants or tranquilizers, will affect the way messages are passed from the brain down to the penis. So anything affecting brain chemistry in any way can do that. In terms, as I said, of anything affecting blood pressure or heart rate can potentially affect flow. Anything that tends to affect the circulation, so beta blockers, for example, that might be used to treat anxiety or slow the heart or treat migraine, they can have an adverse effect. And as I said earlier, painkillers are now emerging as a major problem, particularly those that contain codeine or morphine or anything stronger. Because not only do they affect the nerve pathways, they also lower testosterone level, which I'm sure we'll get onto in a moment.
So is that something that you see with all kind of opiates, codeine and other stronger opiates and painkillers?
Yes, colleagues of mine have done studies in general practice and found that over 50% of patients who have been on repeat prescriptions of chronic painkillers, quite legitimately for, say, something like back pain, have erectile dysfunction and low levels of testosterone. So if you're a patient on those medications, I would urge you to get a check done with your doctor.
I see. So that is good to know. So if you're on opiate painkillers, it would be a good idea for our patients to then test their testosterone levels.
Yes, and fill out one of the little questionnaires about erectile dysfunction. There's numerous that you can get off the internet that are just a few little questions. Can I get an erection? Can I maintain it? You know, how often does it go too quickly? How satisfied I am with my erections? These are simple questions.
Okay. And you've also mentioned antidepressants. So SSRIs have been prescribed in increasing numbers throughout the past few years. is that something that is potentially contributing to higher instances of erectile dysfunction as well?
Absolutely. And not only erectile dysfunction, they also delay ejaculation, which they are actually used to treat premature ejaculation.
Duloxetine.
Yeah. But if you're a patient who has normal ejaculation, then, in say 5 minutes, and you were delayed till 20 minutes, that might sound fantastic, but actually it can be terribly awkward and disturb relationships. And also they can actually prevent orgasm, which makes the sexual activity less enjoyable. So they've got a lot of adverse effect on sexual function.
Okay. And any particular ones, or just SSRIs in general? You see this trend in?
Yeah, I think the older ones, the tricyclics, were even worse. Things like amitriptyline and imipramine. So the SSRIs, drugs like fluoxetine and sertraline that are widely used, they came along as being better. But as they've been used more and more, we've realized that they still have considerable problems.
So to our listeners that might be on an SSRI, clearly that might be something that's very important to them. What would you recommend if they are seeing these kind of sexual problems?
Well, I of course wouldn't recommend them just to stop.
Oh, of course not.
No, because they've been prescribed by a doctor who knows whether they were appropriate for the medical condition. So they should discuss this with their doctor or the practice nurse next time they're there, and look at whether the dose could be reduced or it could be changed to another medication, or whether they should have something specifically to treat the erectile dysfunction. Because if it's necessary to continue treating the depression, you just have to bite the bullet and treat the erectile dysfunction as well.
Okay. So we always like to tell patients, obviously, stop smoking, reduce your amount of alcohol. And these are always just good healthcare measures to keep in mind. How often or how much do you think they contribute to erectile dysfunction?
Well, there have been a number of studies that have looked at lifestyle interventions. There was a big one in Italy where they really attacked all the lifestyle risk factors. Obesity, of course, is another one that is vitally important nowadays. And they found that over about 2 years, it had a mild to moderate improvement. So the message there is that it can be very important in patients with mild erectile dysfunction, somebody who just can't quite maintain the erection for long enough or gets a problem sometimes. But if you're somebody who can't get an erection at all on any occasion, it's unlikely that lifestyle alone will solve that problem. You'll need medication as well, but the lifestyle changes will always be helpful in addition to any medication that's given.
What about obesity in particular? I think we spoke about this before. How much does being overweight or obese predispose you to your erectile dysfunction?
It's an incredibly important factor. If you just think about the physical problems of having obesity and being able to get in various sexual positions and maintain them for long enough. So if you get over those practical problems, you've also got the problems that with obesity comes the other conditions I've mentioned, the type 2 diabetes, the high blood pressure, the raised cholesterol, etc. So all those things build up on top of each other to make it a severe problem.
Great. Thank you for that. So one big question that we often get, Professor Hackett, is how much is erectile dysfunction mental versus physical?
I think this is a very important question because we've always believed in the past that if you were younger, then the problem must always be psychological because, of course, you're not old enough to have got these problems. But that is clearly untrue because if you look at all the statistics now, young men are developing type 2 diabetes in their late teens and early 20s. And of course, with that goes the high blood pressure, raised cholesterol, etc., and also low testosterone levels. And I see a number of patients, for example, who are gym goers, who are using supplements, even anabolic steroids in the gym, And what these do is they suppress your own natural testosterone production, which I'm sure we'll get onto in a moment. And this can be the presenting symptom. They come along with erectile dysfunction. And often it's put down to anxiety because the patient is too ashamed to tell the doctor what they're taking, because they feel that he or she will be judgmental. And it's never helps if the patient is not even telling us the accurate story.
There are some questions that are sometimes raised about erectile dysfunction treatments, or particularly in tablets, being used as a performance enhancement. Do you see that in your practice? Do you see that as a problem?
I don't see this as a problem at all, because in the definition, it says sufficient for satisfactory sexual activity. Now, satisfaction is something that's judgmental. Only the person themselves knows whether they're satisfied. And not only that, you've got to satisfy a partner. And that can be very difficult at times. If you've ever had a partner who said something like, "Was that it?" then clearly you haven't satisfied that partner. So therefore, sex won't have been satisfactory for you. And who is this third party to tell you what is satisfactory for you or not? So patients have different expectations at different ages, different relationships. And so that's what we should be targeting for treatment, not some preconceived idea that the doctor might have. And so I never try to bring my ideas into the arena of the consultation. It's about the partners and patient satisfaction.
So you think it's a little bit of a myth that these drugs are utilized kind of, or abused in a way that they're used for performance enhancement?
Well, it is performance enhancement because we want the sexual experience to be the best it can possibly be.
For the benefit of both individuals, I suppose.
And I doubt whether a partner has ever said to any man, "That's good enough. I don't want it any better." So I think this is a complete non-argument that we're talking about here. And what I've realized over all the years I've been doing this is that what these drugs are doing is they're also treating the underlying cause of the erectile dysfunction. Because as I've said earlier, if the problem is due to poor blood flow through the arteries, these drugs improve the blood flow through the arteries. And if you take them on a regular or ideally daily basis, they are reversing the process which is causing the erectile dysfunction. Okay. So if you had a headache, the answer wouldn't be just to always take a strong painkiller. You'd want to know what the cause of your headache was, and you'd want the medical treatment to prevent your headaches, not just to knock you out for several hours whenever you get one, once or twice a week.
Absolutely. I do want to talk about the treatment options. I think that's one of the biggest questions that we get, and sometimes our patients do get confused about what the options are. First, maybe let's talk about just the tablets. So PDE5 inhibitors, and the differences between the brands, the generics, and in your opinion, what is the kind of the best treatment options?
Yeah. First of all, we need to say that these have been revolutionary drugs. They're probably, Viagra, for example, is probably the most famous drug of the last century.
Yeah.
And the developers of it won the Nobel Prize for medicine. So it doesn't get much better than that. So these have been revolutionary drugs. The important thing to realize is that they were developed to treat heart disease, and they were well down the route because we knew they increased blood flow.
Yeah.
And then by chance, they discovered that the patients wouldn't return the tablets in the trials because they noticed this remarkable side effect.
Yeah.
And all this happened in South Wales. This is why
really?
Morrison Hospital in Swansea is absolutely famous, because this is where this was first discovered by a colleague of mine, David Price. And so this changed really the whole direction of the company's development. But we shouldn't forget that they actually knew what the drug was good for in the first place. All right? So that's why these drugs are very good drugs for the cardiac or cardiovascular disease that the patient has causing the problem. And that we shouldn't think of them as just a treatment of a symptom. They're treating the process. And that's what I spend a lot of my time telling patients. And once you tell them that, it motivates them to continue with the treatment because they begin to see other health benefits.
Right. So maybe let's first just kind of compare the options that patients have. So normally we have Viagra or sildenafil, and we have Cialis, or the generic being Tadalafil. And then we've got Spedra and Levitra as well.
Yeah.
So out of all those, what do you normally opt for in terms of what you treat your patients with? What is your preference there?
Yeah. First of all, we need to explain why do we have all these different names for them. The reason for that is when a company develops one, they give them a classy name like Viagra because people can remember it. That's what we call a trade name. And then when the patent runs out after 15 years, a load of different companies can make it, and for a lot lower cost. So we then revert to the generic name, the chemical name, if you want, which was sildenafil. And so that's what the cheaper products that are widely used now are. Some patients like to have the Rolls-Royce product and always order Viagra. So likewise, when it comes to Cialis, which was really the second major one to come along, that's now known as Tadalafil. So we talk about Tadalafil now and sildenafil. The key difference between these two is that whereas sildenafil or Viagra works for about 4 hours, it has to be taken a half an hour to an hour before planned sexual activity. Because Tadalafil works for 36 hours, you can take it as a low daily dose, and so you can be normalized if you want. You can be able to have sex whenever you would normally have done. So what you're doing there is you're bringing the patient back to the way they were before they had any problem. Okay. So therefore they don't need to give their partner a wink as if something's going to happen in an hour's time because I'm taking a tablet. Right. You go up into the bedroom and be ready when match of the day's finished. That's not exactly the most romantic thing to say. But if you take a low-dose tablet and you give your partner a cuddle of an evening, and then she tells you that she's had a dreadful day at work and she's got a headache coming on, you can make a nice cup of tea, give her a cuddle, and you go to bed nicely. And then in the morning, things might just happen romantically. Now, isn't that the way relationships should go, rather than being orchestrated by the need to take a tablet?
It sounds a lot more natural and spontaneous, doesn't it? So just to be clear, we were talking about a lower dose of Tadalafil. So this is 2.5 or 5 milligram doses that are taken every single day, regardless. So just taken every day.
Yeah.
So do you think that this is the kind of optimal treatment when we talk about these tablets?
Well, definitely, because as I've said earlier, they are treating the cause of the problem as well. And what we find is that the improvement, rather than if you take sildenafil or Viagra, you find that after a year or two, it might be becoming less effective because you haven't been treating the process. If you take Tadalafil, you find that the opposite occurs and the results get better and better because you're preventing progression of the disease process. And it also has another major advantage because it's now licensed to treat prostate problems. And as men of a certain age get older, they develop the need to go and pee rather more often, get up 3 or 4 times at night. It's now shown that Tadalafil prevents the progression of prostate problems with age.
Okay. Well, that's great. So you're saying not only are they treating the erectile dysfunction, they're having more spontaneous sex, but they're also having all these additive benefits, which are vascular and preventing prostate issues.
Yes.
Right.
And tadalafil also is a very useful treatment if given daily to treat premature ejaculation.
Okay.
So we've just written some guidelines on premature ejaculation, and we've actually made daily tadalafil the recommended first treatment for men with premature ejaculation.
Are there any particular side effects that patients need to be aware of when they're on once daily tadalafil?
Well, the important thing with once daily tadalafil, very similar to the fact that if for example, you like a drink and you had 1 pint of beer every day and then you drove home from the pub, you'd probably be perfectly fine. You wouldn't have any side effects at all. If you went out on a Saturday night and had 7 pints, you'd probably feel rather ill. You'd probably be written off most of the following day, and you might even write off your car driving home or get arrested. Same amount of beer in the same period of time. So therefore, having the low dose of tadalafil daily, you get fewer side effects than taking the big dose to force an erection, if you want, in the next hour or two. So the side effects that we do see are a mild headache, slight flushing of the face, slight indigestion, and sometimes a bit of nasal stuffiness. But these usually, they're initially, and they usually wear off with time, the more doses that you take.
So these are things that you would normally see with the other treatments, but just to a lesser extent. And these are all things that are very common with sildenafil as well.
Yes, you rather like the analogy I used with if you take the big dose of alcohol in one go, you get much worse side effects than if you spread your drinking out over a week.
Yeah, that makes perfect sense. So a question that we often get is around herbal remedies. So sometimes patients will ask whether it's safe to use an herbal treatment, and they might be buying these online or in different sources. Can you tell us a little bit about the safety and efficacy of these?
Yes, this really occupies so much of my time, and I can't understand why patients with a serious medical problem will go down this route first. They take stuff like horny goatweed. Now, as if calling it horny goatweed will make it more effective than normal goatweed. Ashwagandha, yohimbine.
But normally you see 10 different ingredients on these things.
Usually just old-fashioned things that are continually recycled. The only thing that changes is that the price goes up each time. No clinical evidence to support them. Work only by placebo effect, and usually the effect, if there is any, only lasts for a short period of time. This is a serious medical condition caused by usually vascular or metabolic problems. It needs to be treated seriously, and patients should be discouraged from wasting their money on these sorts of products. Absolutely.
And we also said about the incidence of side effects with things like tadalafil being relatively low. We know the efficacy is very high. If patients do think they have a problem, they should be seeing a doctor. They should be having a consultation and getting the proper treatment.
Absolutely. And you sometimes need to, when you see your doctor, direct the doctor down the correct route to make sure that you get the investigations and you don't get a brush off like it's possibly stress, or you've been working too hard, or your football team are on a bad run.
Exactly.
Patients, they have to be quite brave to go and see a doctor about this problem, and they need to make sure that they get what they want from that consultation and get the proper tests done.
Exactly. So you heard it from us. Stay away from the herbal treatments. They're not worth it. The risks are too high, and they just don't work. What happens if the patient's taking the tablets, they've taken the maximum dose, and it's still not enough? It still doesn't work. What are the next steps?
I'd like to take us back to square one, really, and say that before you start on any treatment, I said that there's always a cause for the erectile dysfunction. So I think any patient, before they start on the treatment journey, should have some blood tests to exclude raised cholesterol, high blood pressure, type 2 diabetes, prostate problems in the first place, so that they can be addressed at the same time. Unfortunately, in the real world, patients have usually tried a tablet that they've got from somewhere, a doctor who didn't take a proper history, or a friend.
Mm-hmm.
These things happen. And so therefore they don't work. And that's the time when you must do the investigations to try to find out if there's a medical reason why they didn't work. And you then address that medical reason. The commonest reason that they don't work is because the patient has a low testosterone level.
Right.
Because you need a certain amount of testosterone in your body to upregulate the effect of these drugs. And they have been shown time and time again not to work as well in men with low testosterone. And that particularly occurs in men with type 2 diabetes.
I think that brings us very nicely to our next question, testosterone. So out of the cases of erectile dysfunction, what percentage do you think are actually tied to testosterone or low testosterone levels?
Well, the important thing to realize is that there's no such thing as a male menopause. Mm-hmm. If ever you see that written in a journal, it's a total myth. Women have a menopause, which occurs from about age 52, 53, and can last for 10 years or so. Men don't have a menopause. What happens with men is that the testosterone levels tend to fall from about the age of 30 onwards in a gradual fashion. But some men will lose testosterone at a faster rate than others, so that they will run into a problem that's worse than just normal aging. And that's round about 25% of men who will have inappropriately low levels of testosterone for their age. And that usually presents with three common symptoms. One will be loss of libido or sexual desire, less interested in sex, less interested in initiating sex. Loss of morning erections, that one's cropping up again, and erectile dysfunction. Those three things are the best predictors of a low testosterone, and failure to respond to one of the tablets that should normally work will be the other. And so we must measure the level of testosterone if that happens.
25%, that's huge. It's a huge amount of men that are having low testosterone.
Yes, but we've got to realize that as some of these men might be older, they might have stopped having sex, because if they're getting older, their partner's getting older, it's not essential. The rate of sexual activity can fall off and be perfectly normal for that relationship. So that doesn't mean they all need treatment.
And do you think that we're treating enough of these men that are having low testosterone, or is that something that we need to be looking at identifying and treating more, especially in the UK?
We certainly should be diagnosing it, because several studies have shown there's a very close link between low testosterone and type 2 diabetes. They go together very closely. So if you have low testosterone, you have twice to three times the risk of developing type 2 diabetes. And you'll also be overweight, because if you think about testosterone and what it does, it's involved with muscle. If we think about someone who might be taking testosterone, you think of somebody who might be more muscular. So therefore, when your testosterone level falls, you have more fat and less muscle. And that's not good for anybody, because that fat is metabolically active, and that's what causes type 2 diabetes. So surprise, surprise, if you replace the testosterone, you prevent type 2 diabetes. So that's why it's critically important.
So what would be your advice to someone that's seeing less morning erections, having problems with erectile dysfunction, potentially suspecting that it might be testosterone? What's the first step for those people?
I must say, go and see your doctor and tell him about it, because if you present him with that story, then he's failing in his job if he doesn't recognize with those critical symptoms that he should be doing blood tests. And this is actually the earliest way that we pick up type 2 diabetes. the most common presenting symptom of type 2 diabetes is loss of morning erections and erectile dysfunction, but only if you think about it in the first place.
Okay, so we have a patient that has done the blood work. They looked at testosterone levels. They have taken the tablets, and they still haven't worked for them. What options do they have at this point?
Right. Well, earlier on, I discussed the value of taking the daily tablets, and we talked about whether they lose some effect. I think the evidence is exactly opposite. The earlier you treat it, you're treating the disease process, you can actually reduce the chances that you will become a non-responder to tablets by taking the daily treatment earlier. Unfortunately, there will be some patients who either become non-responders or don't respond at all to tablets because they've started them too late and the disease process has gone too far. The first thing you do is try correcting the testosterone level, as we've said. In addition to that, if that still doesn't work, we have second and third line drugs that we might use. Now, the ones that we usually move on to after the tablets would be injections, which have been around for ages. And the two common ones are Cavaject or L-Prostadil, or Invicorp, which is a combination of two drugs and has the advantage that it causes less pain with the injection. Now, patients are usually reluctant to move on to these because who wants to stick a needle in the side of your penis? And if we're talking about spontaneity earlier, it can't really be the most spontaneous thing to disappear to the bathroom to inject yourself. But when you've got serious disease and it's the only thing that works, I'm quite amazed at how many men find this as a reasonable solution to their problem. And they get by quite nicely for many years. Eventually, they can lose their effect, and you might have to increase the dose, use a combination of two injections, combine injections and tablets. You need to sometimes adapt the treatments to suit the patient.
I see. And when we're talking about the injections, what kind of percentage are we of the total ED treatments are we talking about? Is this about 1%, 2%, 5%?
Well, remember they came before the tablets, so they were the only things we had at one stage. So I would say now that less than 20% of the patients will need to go on to injection therapy. We can usually manage by some manipulation to get about 80% responding to tablets.
Okay. And after injections, is there any other interventions that we can use?
Well, there are various things that are coming on board now. If patients do a search on the internet, they'll find that there are things like shockwave treatment, which can be very expensive, and usually you have to go privately for that.
Okay.
And it can cost £2,000 to £3,000, and this consists of a series of 6 to 8 treatments of shockwave therapy applied to the penis at various points. And this is designed to encourage blood flow by breaking down plaque and fibrosis. It also can work for something called Peyronie's disease, which is where the penis has a bit of a bend. The problem is there's no guarantee, it's expensive, and the evidence shows that it doesn't work in the most severe cases. So the slight paradox is that it would be nice if it worked in the ones who failed with the tablets, but in fact it doesn't seem to be panning out that way. The other thing that you can have is an injection of something called protein-rich plasma, or PRP, where they take a blood sample and they spin it down and they inject all the goodies from the blood, from the plasma, back into the penis to encourage some rejuvenation of the penis. And this is offered in some private clinics. It's early days yet. It does seem to have some effect, but the evidence is that it has to be repeated because the effect isn't permanent. The other thing that you can do is there's a device called Vertica, which is where you have electromagnetic waves, and you buy a device and you use it repeatedly, and it improves the structure and blood flow to the penis and helps to preserve erections. Okay. Early days with that, no long clinical trials. And if all else fails, patients are often referred to a surgeon for a penile implant.
This is the last resort, the penile implant.
Another thing I might mention is that some patients can use a vacuum device where you put a tube over the penis, use a pump which draws blood into the penis by pressure, and then you put a ring at the base of the penis which maintains blood there and helps you to get a rather cold erection, but often one that's sufficient for sexual activity. And I find that as soon as I take that out and show it to patients, if somebody looks at it and takes it off me and says, well, that's very interesting, how does it work? I realize that we've got a chance. If I see them opening their newspaper and reading the Times as I'm demonstrating it, I realize we've got no chance.
Gotcha. Yeah. We've seen that. We've seen that before. I think the penis pumps have been around for a while now. What are the dangers of that? Are they quite safe to use, or?
Well, the dangers of them are that if you leave the restriction band on at the base for too long, you can actually be cutting off the blood flow to the penis. Okay. And so you shouldn't leave it on for, more than 30 minutes or so, because otherwise you might need to go off to the hospital and have some procedures done to recover. But that seems to be common sense. We don't see that very often nowadays.
So always the inherent risk with those.
Yeah.
But still, we have some exciting things that are in the pipeline, so to speak, with the other treatments like the shockwave therapy.
Yes, these seem to have potential, and there's new things coming along, and often we're combining these things with tablets, for example, and we're getting an additive effect by using more than one treatment together.
Yeah, I was going to say you probably are also using the tablets on top of the treatment as well, just to get the maximal effect.
Yes, it's often better, rather than going from A to B to C to D, to go from A to A plus B and A plus B plus C, rather than dropping the one that worked partially.
Okay. So say, for example, we have a patient that is perfectly healthy. They have no problems with ED. But that might be something that is a concern for them in the future. What would you recommend to them to do in terms of lifestyle measures to make sure that they're in optimal health and then they're preventing themselves from developing erectile dysfunction in the future?
Well, there's very good evidence that losing weight improves erections.
So stay active, stay fit.
Stay active, eat healthily, keep the fat off, because as we've said, the fat is metabolically active and will not only lower your testosterone level, but it'll be associated with the inflammatory components that can affect our arteries. And so that's a good general health measure. But there are benefits from exercise alone. Every period of moderate to strenuous exercise improves insulin sensitivity for about 16 hours. So you can actually reduce your chances of developing type 2 diabetes with regular exercise. There's also a lot of cognitive, mental benefits from regular exercise. It's a great treatment for depression because, as we intimated earlier, depression can be an important factor in erectile dysfunction as well.
What kind of exercise would you recommend? Anaerobic, aerobic, a mixture of the two?
Mixture of the two. I find that finding the right exercise for a particular patient, you need to discuss what they do already, because if somebody's a regular gym goer, then it's easy to adapt their training program. But if it's somebody who's never been to a gym, you might just have to start with regular walking and gradually build it up, so they do walking for at least an hour a day.
So pretty common sense things: staying active, staying fit, making sure you keep your weight down to a healthy weight. What would you recommend for patients are on a vegetarian or a vegan diet, would that predispose them potentially to erectile dysfunction or low testosterone?
Well, as long as they're not becoming deficient in certain vitamins, particularly vitamin D, so they should have that checked. If they've got to be having enough protein.
Yeah.
But generally speaking, there are probably more benefits to vegan diet as long as you're watching your vitamin supplements to the average English diet, which we know is causing more and more type 2 diabetes year by year, and we keep trying reinventing measures to improve the UK diet every year, and we seem to keep failing regularly.
As long as they're getting enough protein and healthy fats.
Yeah, and vitamins.
And vitamins. Okay. So touching a little bit about erectile dysfunction and relationships, how should someone talk to their partner about ED?
It's absolutely important that we bring the partner into this. One of the problems with the conventional doctor-patient relationship is that it's a patient talking to the doctor. This is totally different from every other medical condition because there's a third party involved in this, and they're often not there to put their side of what's happening, and they're as intimately involved as the patient is. So we always need to be conscious of this. There also may be religious, cultural, racial variations that we need to be aware of. We might have arranged marriages, all sorts of things that we need to know about. So we need to always consider that erection in the context of the relationship. And it's very difficult sometimes. I used to see patients in the clinic and I tried absolutely everything. And then suddenly I'd get a note as I started my clinic from the wife saying, please don't give my husband anything else. He's really annoying me the whole time. And then I realized that I'd been wasting my time and this chap was never going to get any success from the treatment. Conversely, you need to be aware sometimes that it might not be the partner that he's having the sexual relationship with. And we can't be judgmental because our duty is to our patient. So we need to always keep an open mind. We also need to be aware sometimes that it might not be our idea of sexual activity. There's a lot of variation. Some patients don't necessarily want to do the full thing. I've actually treated some men who just want to be able to masturbate normally, and you need an erection for masturbation. And who am I to say what constitutes successful sexual activity for that person? It's down to what they enjoy, not what I think they should enjoy. So we need an open mind.
So how do you think couples can maintain intimacy when dealing with ED or going through the process of the treatment?
Well, I think it's important to actually see them as a couple, because if you can explain to the partner, the mechanisms, because often the partner thinks he doesn't love me anymore, he doesn't find me attractive. And in fact, nothing could be further from the truth. It's because he does love them so much that he finds them so attractive that he gets so down when he can't perform. And that repetitive failure makes him more despondent, makes the problem worse. So if you can break down those barriers, if there are things about the technique that's important, because men as they get older need more direct genital stimulation, and yet they're often with a partner who is less inclined to stimulate them. It gives you an idea of how you sometimes have to go back and discuss intimacy, that the sexual contact before penetration is at least as important as the act itself.
So it's having that open communication as well, isn't it? So making sure that the two parties are having the same expectations. They know where each other is coming from as well.
And sometimes I've seen a couple who've come in and they might as well be sitting, 10 yards apart, who after you've had the conversation, they actually leave the room hand in hand. And you've clearly made some impact by by facing these problems head on.
And what role do you think therapy or counseling can play in this picture?
Counseling can be absolutely vital, because when even in the situation I've discussed, you've still got the problem that the partner might feel that there's two ganging up against one.
Yeah.
So the beauty of counseling is that it can be on the partner's terms. It can be someone that they've chosen to counsel, and they feel that it's much more of a safe space. Also, as well as doctors or nurses, we can't help our gender. There's nothing I can do about my gender. It's too late to try that, I think. So they might feel safer in a safe space if they had a woman present who might they perceive would be more understanding of their issues.
Okay.
It's an ideal situation. The realities of working in the NHS are that we've got a shortage of therapists, whereas we might have to crack on and do some treatment, but we have to wait several weeks for the therapist to become involved.
I see. So it's a two-pronged approach, having the therapy and also having the medical intervention there.
Yes, I'm lucky enough to be very good friends with some excellent therapists, and I help them out and they help me out, and it works very well, but other doctors won't be so lucky.
Brilliant. Thank you. So just going back to the testosterone treatment, can you tell us a little bit about the benefits of identifying and then treating low testosterone levels that you've seen in your own practice?
Treating low testosterone levels in men can be one of the most rewarding things I've ever known in medicine, because I have patients come in who not only have the sexual symptoms that we've talked about, but they have other symptoms, particularly excessive tiredness, poor motivation, reduced concentration. It can manifest itself by things like coming in of an evening and falling asleep, or more or less immediately. Worse than that, falling asleep at work, which doesn't go down too well generally. And what definitely doesn't go down very well is falling asleep if you drive a motor vehicle.
Yeah, that's a big
no-no. The number of times
no-no.
I've had van drivers, for example, who have to pull over when they're driving, and have a sleep for about an hour or so in the middle of the afternoon. And this often doesn't go down too well with their bosses, and they can lose their job. Or even worse, they don't pull over and they have an accident. And I can remember 3 or 4 cases like that.
So this is a big warning sign, actually.
Absolutely.
Tiredness.
Yeah. And it's strongly associated with sleep apnea syndrome, which is where people have restless sleep at night, and they can actually come quite close to stopping breathing. So it's important in those aspects. So also depression, because if these things are happening in your life, you get low mood, you'll be concerned about it. So those are some of the major things that patients are often not mentioning, because they just put it down to age, hard work, anything else, drinking a bit too much, which may or may not be true. So any of those symptoms, particularly combined with the sexual symptoms, we must always do a testosterone level. And whereas we often think as doctors about checking thyroid, we're often not so good at thinking testosterone. And so often these men get put on an antidepressant because it's perceived it must all be due to the fact that they're depressed.
No, exactly. And have you had patients, come back to you and say, Dr. Hackett, this has been life-changing. It's changed my life in such a positive way.
Every year we have to produce an appraisal where we have to provide feedback from our patients. And since I've been doing this, the biggest problem I have is that my appraiser reads my feedback, and they must think that I've written it myself, because I'm just embarrassed by the number of patients who come back and say, I sometimes have to almost do a double take because I don't think it's the same person I saw previously, because the chap who was nodding off when I was speaking, which happens actually more often when I'm talking to my wife. But now he's alert, he's listening to everything. The interaction with the partner is terrific. And quite often, it's actually as the partner's leaving, they grab your hand and they say things like, "Thanks for giving me back the man I married." Now,
wow, that's amazing.
If this is one of the reasons I continue working, because you get a real lift from
that must be such a great feeling to see that you've made such a great impact on someone's life.
Yeah, and there's nothing else that does that I've ever seen.
That's fantastic. Well, thank you so much, Professor Hackett.
Thank you.
This has been a really insightful podcast. Thank you for coming. You're a great wealth of knowledge. And if any of our listeners have any other questions, please leave them in the comments. Like and subscribe. And check out our new Spotify channel as well. Thanks for listening.